Welcome everyone to Us Two's first webinar for 2021. My name's Terry Lakowski and I am the program director from Us Two, and I will be your host tonight. Tonight's webinar on bone health and nutrition is episode 1 of a series of 5 called What is Right for Me in My Prostate Cancer Journey. And tonight's program is sponsored by Amgen. I'm really excited to share that we have almost 750 people registered for this video tonight. We have 16 countries, including Canada, South Africa, Luxembourg, Italy, Colombia, Bahamas, Zimbabwe, Belgium, the UK, Nigeria, Finland, Taiwan, Australia, India, and Egypt. I think that's always my favorite part, to see how big our reach has gotten through Us Two. So welcome everyone. We're thrilled to have you here. Us Two is here to empower men diagnosed with prostate cancer and their loved ones with educational resources and support services to help fight prostate cancer. Our website offers a wealth of information at no cost to help make informed decisions on prostate cancer testing, active surveillance, treatment options, and management of side effects. Through our support groups, and now due to COVID, we have over 70 virtual groups. We have support services, newsletters, educational materials, and events. Us Two will help transform resignation into determination and fear into hope. One of the challenges that men are facing in selecting a treatment plan for prostate cancer is that there is no single standard that applies to every man's situation. With this webinar series, What is Right for Me in My Prostate Cancer Treatment, Us Two will try to help patients and caregivers understand their options and provide information to help each person make the best choice for his own unique circumstances. Part of Us Two's mission is to help ensure that support group leaders and prostate cancer patients and families have access to the latest information about new pharmaceutical products, therapies related to prostate cancer. While we do not endorse particular drugs or services, we do want you to be aware of what's currently available so you can make the best possible decisions in conjunction with your physician. I just want to go over just some really brief housekeeping tips before we get started today. There is a Q&A box on the bottom of your screen. You'll see there's a Q&A box and there's a chat box. So I want to make it really clear that because we have so many folks on, it's going to be really hard for us to answer all your questions. And we also actually had a lot of questions that already came in ahead of time. To be exact, we had like 214 questions that came in ahead of time. So we have those ready to go. But go ahead and put some questions in the Q&A. And then the chat box is specifically for just what you guys are already doing, just to say hi if you have any comments about what's happening. If you have any technical difficulties, we've got the Us Two staff watching the chat box, and they can help you out there. So if there's any issues, kind of put that in the chat and someone can help you out. The other thing that I want to mention is if you go to the very top right hand of your screen and you see view options, hit side-by-side view. So that'll be your best view for the webinar. When the slides start, when everything starts with the presentations, you will see the slides, but then you will also see the presenter's face. So again, go to the top of your screen, hit view options, and just click on the side-by-side view, and that's probably going to be your best view. So we've got a lot to cover, so let's get started. I'm really honored and excited to introduce our moderator tonight. He's my good friend, Dr. Jamie Kearns. Dr. Kearns is an assistant professor of urology at Atrium Health and Levine Cancer Institute in Charlotte, North Carolina. His research interests are in understanding racial disparities in prostate cancer screening, diagnosis, and treatment, with the goal of leveraging the electronic health record to decrease these disparities. His clinical interests are diagnosis and treatment of prostate cancer, including PSA screening, MRI fusion biopsy, and robotic prostatectomy. He's also a member of the US2 Board of Directors, and we are absolutely thrilled to have Jamie as part of our board. So let's welcome Dr. Kearns.
Thank you so much for that kind introduction, Terry. Very excited to be here tonight, and I'm very excited to introduce our two speakers tonight, Dr. Gregory Lewis and Christine Palumbo. Dr. Gregory Lewis, MD, is a senior urologist at Advanced Urology Associates and AUA Prostate Cancer Center. Dr. Lewis is a native of the Chicago area. He received his Bachelor of Science degree from Purdue University and graduated cum laude from Loyola University Stritch School of Medicine. He performed his general surgery internship at St. Francis Hospital in Evanston and completed his urology training at the VA Hines Hospital and Loyola University, including a 6-month rotation in pediatric urology at Children's Memorial Hospital. He is a member of a number of honorary medical societies. Dr. Lewis is certified by the American Board of Urology and is a fellow of the American College of Surgeons. Christine M. Palumbo, RDN, FAMD, is an award-winning registered dietitian, nutritionist, and wellness expert in Naperville, Illinois. Her entrepreneurial career includes freelance writing, corporate wellness, nutrient analysis, corporate consulting, and dietetic education. For 10 years, she wrote the Good Sense Eating column for Chicago Parent Magazine and also for Manhattan Family. She also penned the popular food news column for Allure magazine for 9 years. Christine is frequently featured in print, broadcast, and social media and has hundreds of interviews under her belt. A highlight of her career was the day she was a guest on the Oprah Winfrey Show. A national leader of the Academy of Nutrition and Dietetics, she was awarded its prestigious Medallion Award in 2018, one of 11 awards that have been bestowed upon her over her career. So to begin tonight's presentation, Dr. Lewis is going to give us about a 20-minute talk on general bone health, followed by discussion from Christine, and then Dr. Lewis will come back and speak with us again. So I'd like to hand it over to Dr. Lewis now.
Well, welcome everyone. Thank you. I'd like to personally welcome you all and express my gratitude to Terry Lukowski and Tracy Cameron and the staff at US2 for giving me this opportunity and privilege to speak to you all on this important topic of bone health. And thank you all, members of our audience, for taking time out of your schedule for joining us this evening. It's a picture of our primary office in Joliet, Illinois. It's an independent private practice urology group of 9 urologists and 1 radiation oncologist and 90 employees in our 3 offices. I don't know about the weather where you're all at, but it's winter here and it's been a lot of snow, a lot of cold weather. So through the quote in there, time in the winter evenings should not be wasted for fear that one day time might waste me. So let's get started. In 2004, the U.S. Surgeon General published the very first ever report on the nation's state of bone health at the request of Congress. And the major theme of that report was bone health is critically important to the overall health and quality of life of Americans. Another major theme of that report was that unhealthy bones can lead to debilitating fractures, by far the most important consequence of poor bone health, since fractures can result in disability, diminished function, loss of independence, and premature death. I wanted to preface our discussion tonight by the Surgeon General report because of the ever increasing aging of America and the increasing incidence of osteoporosis and osteoporotic fractures, which poses a tremendous financial and emotional burden on not only the patients that have osteoporosis, but also on their families and society as a whole. We have the knowledge to prevent it. We have the technology to detect it. We have effective medications to treat it. And yet still in 2021, the biggest problem is a lack of awareness of bone disease among both the public and healthcare professionals. My goal tonight is to provide you with as much information as the time allowed. This presentation is basically a summary review, as we could easily spend 30 to 60 minutes on each of these topics. But hopefully the information that I provide you tonight will pique your interest and help you better understand and realize the importance of bone health in men and empower you to deal with your own personal journey and decision-making going forward. Hope from tonight's presentation that you'll gain enough knowledge and motivation to seek out more information on your own and to feel free to carry out an open discussion with the various healthcare providers that are involved in your care. The presentation tonight will consist of two parts. The first half will discuss about osteoporosis in men in general, and then the second half will narrow it down to the relationship between prostate cancer, androgen deprivation therapy, bone loss, and bone metastases. So sit back, relax, enjoy, put my foot to the gas pedal as we go through a lot of slides here to try to provide you as much information as time allowed. So a few definitions. Bone mineral density refers to the degree of hardness or mineralization of our bones. It can be measured by a test called densitometry or bone density scan. Osteoporosis, the word means porous bone, and it's a systemic skeletal disorder characterized by low bone mass and structural deterioration of bone tissue, with a subsequent increase in bone fragility and susceptibility to fracture. Osteoporosis is the most common bone disease that we face. Osteopenia, also called low bone mass. It's a condition where bone mineral density is lower than normal and considered to be a precursor to osteoporosis. No, these three graphic pics are not various brands of Swiss cheese, but rather illustrations of what normal bone density and structure looks like in real life. On the far left, you see what normal bone mineral density looks like. In the middle, osteopenia, and on the far right, osteoporosis. And I think you can tell by the slide on the far right, or the osteoporotic structure on the far right, how that might be much more prone to breaking and fracturing. A couple of misconceptions that I sometimes see in my practice. Osteoporosis is not the same as osteoarthritis, which is the degenerative arthritis of the joints. And a bone density scan, which is used to measure bone density, is not the same as a bone scan, which is a nuclear medicine imaging test of the total body skeleton, usually used to detect metastatic cancer. Silent killer diseases are diseases that produce minimum or no symptoms and are capable of causing death if not treated. In the earliest stages, when these diseases are best detected and treated, they cause absolutely no symptoms. And by the time they progress to a more advanced and sometimes more difficult stage to manage, they can be deadly. Osteoporosis is often called a silent disease because it occurs without symptoms. You cannot tell that your bones are getting weaker, and often the very first sign is a fracture. Osteoporosis is a risk factor of fractures, just like heart disease, just like hypertension is a risk factor for heart disease, stroke, and chronic renal disease. Well, what do we know? Let's look at some of the facts about osteoporosis, and we'll kind of run through these. It's a major health threat for an estimated 54 million American men and women, accounting for 55% of the population 50 years and older. Counts for more than 2 million fractures annually in adults over the age of 50. Medical expenses from osteoporosis-related bone fractures cost $57 billion annually based upon 2018 data. And interesting and important as this point is that according to the National Osteoporosis Foundation, 1 in 2 women and 1 in 4 men, let me say that again, 50% of women, 25% of men over the age of 50 years will experience an osteoporotic fracture in their lifetime. Osteoporosis is associated with 500,000 hospitalizations, 800,000 trips to the ER, 2.5 million visits to physician offices, and 100,000 people placed in nursing homes per year because of this disease. Regarding hip fractures, 1 in 5 people end up in a nursing home within 1 year after hip fracture. 1 in 4 people become disabled. 1 in 4 die within 1 year. At 6 months after hip fracture, only 15% can walk across a room unaided. Many people, as one might expect, become isolated and depressed. A prior osteoporotic-related fracture is associated with an 86% increased risk of another fracture, which brings on the phrase fracture begets fracture. And the very first fracture is a sentinel event, and often an event that too often gets ignored. It should be a call for action. Despite increasing public awareness, osteoporosis is mainly recognized as a female disease. And yes, it is true, 80% of those affected by osteoporosis are women. But 42% of men over the age of 50 have either osteoporosis or osteopenia. Estimated lifetime risk of experiencing an osteoporotic fracture in men over the age of 50 is 25 to 30%, which is more than two times the lifetime risk of developing prostate cancer, which occurs in approximately 1 in 8 men. The mortality of a hip fracture is greater in men than in women. 1-year mortality for men is 30 to 35%, twice of that as seen in women, and men are twice as likely to die in a hospital after hip fracture. I don't want to minimize the consequences of this disease in women. Both men and women experience serious consequences from fractures, but men just seem to do worse and have a higher mortality for a number of reasons. And perhaps the saddest and most impressive fact is that only 10 to 20% of women and even a much lesser percent of men are identified, diagnosed, and or treated. Unfortunately, despite plenty of support and data about osteoporosis, most men, most doctors, most organizations, and most governments across the world are either not aware of the condition or they ignore it. And when a male patient enters a doctor's office, the doctor's thinking of heart disease, diabetes, blood pressure, cholesterol problems, perhaps prostate, lung, and bowel cancer, but osteoporosis and fractures, never or rarely. Osteoporosis is an equal opportunity disease that affects any sex, race, or ethnic distribution, and yet men are often ignored when it comes to detection and treatment. Think of it this way. Imagine if you had a cardiac event, such as a heart attack, an arrhythmia, congestive heart failure that required hospitalization. You would not leave that hospital with either some type of procedure, pacemaker, stent, cardioversion. You would not leave that hospital without some kind of medication, blood pressure, cholesterol med, diuretic, blood thinner, and you would leave the hospital without being given a follow-up to see the cardiologist. Yet, in effect, this is exactly what happens to men when they present to a hospital or ER with a fracture. Let's look at the basics of bone development. Bone is living, growing tissue made up of collagen and calcium phosphate. Many things can interfere with the development of a healthy skeleton, including genetic abnormalities, nutritional deficiencies, hormonal disorders, lack of exercise, immobilization, smoking, alcohol use, medications, and more. Yet a lot of these factors are modifiable. Upper left picture, your body reabsorbs old bone by cells called osteoclasts and creates new bone by cells called osteoblasts. Bottom left picture, there's a remodeling cycle of equal old bone breakdown and equal new bone formation to help keep our bones strong and healthy. The skeleton actually probably replaces itself completely every 10 years. And bottom slide on the right, bone loss occurs when more old bone is reabsorbed than new bone is created, leading to osteopenia and osteoporosis. Upper picture, these are superimposed graphs. The blue one is a graph of the bone density in male. And you can see where we as men reach our peak bone mass. in our early 20s, and then there's this gradual age-related decline as we get older, in the absence of any other risk factors that might further accelerate decrease in that curve. Women reach a much less peak mass, peak bone mass, and then around 40 or 45, when they hit menopause, for a period of about 10 to 15 years, there's a marked decrease in bone density. This is one of the reasons why women often present 10 years earlier than men, again, in the absence of other risk factors. And then this lower slide just shows that as children are growing up and becoming adults, whenever there's nutritional deficiencies or bad diets or other factors going on, they may reach even a lower bone mass, which kind of gets to the point that the treatment and prevention of osteoporosis actually begins early in childhood. What are the common sites that osteoporosis affects? Well, this picture illustrates the most common sites and the most common areas that are fractured: the hips, the vertebrae, the pelvis, the wrist, and less commonly the humerus, and rarely hands, feet, or below the knees. The lower right picture here is an idea what an osteoporotic pelvis and left hip might look like. And I think you can sort of come to the conclusion that if someone were to fall on that, how easy that hip or femoral neck or pelvis might break and sustain a fracture. Turn your attention to the bottom left picture here with the blue arrows. This is a picture of 4 vertebrae. And I think you can tell by that sort of spongy, deteriorated architecture that there's a problem. And the top 2 vertebrae are an example of a compression fracture. Looks like someone just put their foot on top and squeezed them down. Most of us are probably in our lifetimes have come across older women that look like this. This is called Dowager's hump, and it's basically due to compression fractures of the anterior aspect of the thoracic vertebrae, causing this bending over of the upper back and a protuberant abdomen. Well, how about fractures? Because that really is what is the underlying cause of the morbidity and mortality of osteoporosis. A fragility fracture is a fracture that occurs spontaneously or with minimal trauma, such as a fall from equal to or less than a standard height, such as if you slipped on the ice, or you fell out of bed, or you tripped over some stairs and broke a bone, or even having a cough and breaking a bone. This is called a fragility fracture and is almost diagnostic or suggestive of osteoporosis and severe bone loss. The great majority of fractures, close to 2/3, involve the wrist, spine, and upper femoral bone and hip, causing significant morbidity, significant impact on quality of life, the ability to live independently, and with an increased morbidity and mortality rate. About the risk factors for osteoporosis. Well, here's a list of the most common risk factors that are involved in osteopenia and osteoporosis and osteoporotic-related fractures. Age greater than 70, low body weight, a weight loss of more than 10%, nutritional deficiencies, physical activity, smoking, chronic alcohol use, prolonged use of corticosteroids, people who are on prednisone for long periods of time, low testosterone, androgen deprivation therapy, we'll talk about that in the second half of the talk, and goes on previous fragility fracture and an increased likelihood of falling, all risk factors for osteoporotic-related fractures. Well, how do we make the diagnosis? Well, medical history, bone density test, and what's called a FRAX score are the most important. A scan known as the Dexa Scan, which stands for dual energy X-ray absorptiometry, is the gold standard and the test that most of us use to make the diagnosis. There are other tests that are available, but the Dexa Scan remains the gold standard. It's a painless test. It's non-invasive, requires no prep or injection, and it takes just a few minutes to do, and it's about 1/10 the amount of radiation than one would get with a standard chest X-ray. The Dexa Scan measures bone density, bone mineral density at the sites that are most commonly fractured: the hip, the lower spine, and the wrist. And it compares your bone density with that of a healthy young adult. And we measure that by what's called a T-score, which is a measure of the standard deviation from the normal mean of a young adult. Osteopenia, or low bone mass, is defined as a T-score between -1 and -2.5. Osteoporosis, a T-score below 2.5. And if it's associated with a fragility fracture, we call that severe osteoporosis. For each one standard deviation reduction in bone mineral density, that's one T-score from another, the relative rate incidence of fracture increases 1.5 to 3 times. But bone mineral density is not the only predictive tool of fracture. FRAX, which stands for Fracture Risk Assessment Tool, looks at 11 different risk factors involved in osteoporosis. And on the basis of those 11 risk factors, it tells us what's the 10-year probability of either hip fracture or the 10-year probability of a major osteoporotic fracture, and can be helpful in determining who to treat and who not to treat. These are the risk factors that are looked for in a FRAX algorithm. And on the basis of the answers to these 11 questions, a score is given, and then results in terms of what's the chance that you would develop a fracture in a 10-year period. In terms of guidelines, who gets treated, who does not, this is just a list of various organizations that have made guidelines, but basically most would agree that any man age 70 and older, a man who's 50 to 69 who has more than one risk factor listed here, an adult age 50 who's had a prior low trauma fragility fracture, and some of the lesser indications below would all be candidates for a bone mineral density test. A FRAX tool can help guide treatment and reports the threshold for treatment with a 10-year probability of a hip fracture greater than 3% or a major osteoporotic fracture greater than 20%. Again, the diagnosis, the challenge, the goal of detection is to identify people at high risk for fracture before they fracture, and to target for treatment people with low bone mineral density who are at a high risk for fracture. Hopefully, when all of us get our bone density scan, we're going to get a T-score in the green range and not the red range. Let's run through prevention and treatment. The 2004 U.S. General Surgery Report sort of developed a pyramid to look at the various factors that are involved with treating and preventing osteoporosis. The base of the pyramid has to do with a strong foundation involving nutrition and lifestyle modifications to support bone health. And as part of this base includes nutrition, calcium and vitamin D supplementation, which Christine will go into further in a short period of time. No smoking, avoiding excessive alcohol, exercise. Like muscle, bone is living tissue that becomes strong with exercise. So resistant exercises, weight-bearing exercises, all very important. Fall prevention. Falls contribute to fractures. 90% of hip fractures are related to fall. So a lot of attention really should be given to fall prevention, and one could have a very an entire discussion on that. Second stage in the pyramid is just identifying and addressing secondary factors that are involved with osteoporosis. We won't go through this list in detail, but just gives you an idea of how many other diseases may impact on bone mass and bone health. And there's a number of drugs that some of our patients are on which contribute to bone loss, especially corticosteroids and prednisone, and of course the gonadotropin releasing hormone agonists involved with prostate cancer, again, which we'll touch upon in the second part of the talk. And lastly, the third and top level is to determine which patients may be candidates for pharmacotherapy, drug therapy. When you add medications, should probably be based on age and risk of fracture. And here are some of the guidelines. If you're a man over the age of 50 with a previous fragility fracture, you have a T-score of at the hip or spine less than 2.5, or a T-score between -1 and -2.5 with an abnormal FRAX assessment. Although guidelines are very helpful, treatment decisions should be individualized and a shared decision-making between the patient and the clinician. And this is just a list of medications that have been approved to increase bone mass in men with osteoporosis. I won't go into these in detail, but these are the medicines that are available. And lastly, for those who are looking for some more information, here's just a list of organizations, not intended to be complete in any way, but for those who want to pursue it further, these would be surely helpful places to start. So at this point, I'm going to turn the talk over to Christine and back to Jamie.
Dr. Lewis, thank you for that fantastic overview, and looking forward to hearing the rest of your talk in just a few minutes. Christine will now be joining to talk to us about nutrition to support bone health. Looking forward to hearing about this.
All right. Hello, everyone. Thank you, Dr. Lewis. That was really interesting. I am actually going to build on what you said by elaborating on the nutrition portion of what you mentioned. And I want to say at the beginning that while the bone building medications that you mentioned at the end are the backbone, get it, of treatment, there is much that you can do, you out there in who are participating in this presentation, there's much that you can do to support it by the daily dietary choices that you make. So this is what I'm going to cover. As you can see, my slides are very different than Dr. Lewis's. I've got, I'm going to have a lot of images of food, and so I hope you enjoy that. So there's evidence from research studies that continue to suggest that certain nutrients, vitamins, minerals, food groups, and even dietary patterns can play an important role in skeletal health. So we're going to spend the majority of our time on nutrients that make a difference and where to find them. We're going to touch briefly on possible bone robbers, and then finally, how to eat. We're going to give you some food ideas, some menu ideas, and then something else I want to say too is that, you know, in preparing for this presentation, for researching this, I found a lot of inconclusive information, a lot of studies, a lot of articles where it said more research is needed. Or, you know, we know this is true in animals, but not necessarily in humans. Or we've done certain studies, but not clinical studies. So, you know, just keep in mind that what we're talking about today, what I'm presenting today about diet and how diet can influence your bone health could change in a few years, just because medicine, nutrition is a dynamic. Is dynamic, meaning it's changing. We're learning things every day, and it's good to, you know, it's good to keep up to speed on the various changes. So here are some of the nutrients that can influence one's skeleton. So of course, Dr. Lewis mentioned the calcium and the vitamin D, but know that there are other minerals and vitamins that can also make your bones healthier. And I know we have, not only do we have men who are participating in this, we have women as well. They're the men's partners, their spouses, their loved ones. And so, you know, you're watching this, you're participating in this for your male partners, but maybe you're interested in this on a personal level. Since osteoporosis is common in women, as Dr. Lewis said. So let's talk about calcium and some specifics. So the recommended dietary allowance, or the RDA, for men between the ages of 19 and 70 is 1,000 milligrams a day. And then once you hit the age of 71 and up, the RDA is 1,200 milligrams. And for women, women ages 51 and up, so presumably that would be postmenopausal women, would be 1,200 milligrams. And that it pretty much peaks at that point. If you're a woman and you are, say, 48 and you are postmenopause, then you should also take 1,200 milligrams. So that it's not so much the age, but it's the your menopause status. So for best absorption, so here's a concept. It's not so much what you take in terms of pills and takes in terms of nutrient supplements or even food. It's what you ingest, but also what your body is able to absorb, the bioavailability. Bio, of course, refers to life. So for best absorption, calcium should be consumed first from food, okay? And you want to limit your consumption of calcium to between 300 and 500 milligrams at a time. Why is that? Because that is all your body can absorb. So if you are taking, say, a supplement and it's 1,000 milligrams and you take that in the morning and you go, okay, I'm done for the day. Well, maybe not, because you want to split it up. So, if you can get something that's smaller, if you're taking a supplement, you want to take it, again, between 300 and 500 milligrams at a time. Is it going to be a problem if you take the 2,000 milligram capsules? It's not, but your body's not going to absorb all of it. So just keep that in mind. One of the questions that came in ahead of time, and I thought I would just answer this at the, in my presentation, is how much calcium is too much. And the upper limit, at least when it comes to supplements, the upper limit is 2,500 milligrams a day. So you don't want to go over 2,500 milligrams of calcium in supplement form per day. So I think that's that for that slide. Why is it best to get it from food? Because the body absorbs it best. So I've got a little chart here. So on the left, you've got some foods and the amounts. Some of these are dairy foods. So the amounts on the left, for example, 8 ounces of dairy milk, 6 ounces of yogurt, 1.5 ounces of cheddar cheese. Up top, that will provide 300 milligrams of readily absorbable calcium. There is some evidence that the sugar that is naturally present in milk, the lactose, aids in the absorption of the calcium. And then for people who prefer plant-based milks, plant beverages, such as soy milk, or, well, there's a myriad of other plant milks. There's oat milk, which is now the #1 plant milk. You've got almond milk, rice milk, hemp milk, coconut milk, and cashew milk. You have to look at the label. So when I was at the grocery store the other day, I was looking to see how much calcium is present in, for example, almond milk. Most of the brands had a lot. Most of the brands had, say, 450 milligrams per 8 ounces. But I did find one brand that had 0 calcium in it. So you want to definitely read the labels for calcium when you're buying those plant-based milks. There are other types of foods with other amounts. So for example, the calcium added orange juice, you can get 265 milligrams, at least for one brand, in 6 ounces. If you eat frozen yogurt, well, it's not that high, it's lower. Cottage cheese, even though it's dairy, it's lower in calcium. And then sometimes when you read about plant-based sources of calcium, you see oranges have calcium. Well, oranges do, but not that much, only 50 milligrams. Okay. Going back, wait, one more thing about plant-based milks. If you buy a plant-based milk, before you pour it, you want to shake it. You want to shake it very well, because the nutrients that have been added to it, the calcium in particular, it kind of settles at the bottom and it turns into like a sludge. You want to shake it really, really well to distribute all of that calcium so that you are taking it in, you're ingesting it. Okay, glad I remembered that. And then for people who are vegetarian, or perhaps you're even vegan, can you get calcium from those types of foods? Well, it depends. There's a list of foods that where the calcium is well absorbed, and then there are foods where it's not well absorbed. So the cruciferous vegetables, such as broccoli, bok choy, turnips, and mustard greens, collards, kale, those are well absorbed. Cruciferous vegetables, if you grow them in the garden, they have like a little cross when they're coming up. And they're also the types of vegetables that if you cook them too long, they get really stinky in the kitchen. And a little tip to avoid that is not to overcook it, but also the day that you buy it should be the day that you cook it. So when you're cooking those vegetables, buy it and cook it that day or as soon as you can. Soy foods, very well absorbed. Tofu, which a lot of vegetarians and vegans eat, that and it's delicious. If you buy the calcium set tofu, you're good. And then, of course, fish with bones. So some of you are looking at this slide and going, ew, sardines. But guess what? They're a tremendous calcium source. And if you think about it, fish bones, just like human bones, that's where the calcium is stored. Another source of calcium in fish would be salmon, canned salmon in particular. And you want to look for the calcium, you want to look for the canned salmon with bones. And because of the canning process, the bones get very soft and you can mash them. So that's a really easy way to get calcium in the diet, whether you're vegetarian or not. I eat both on a regular basis, and it's a good way to not only get the calcium, but you're going to get some vitamin D as well from both of those foods. So on the not well absorbed side, you've got greens, such as spinach, Swiss chard, beet greens, legumes, which is a fancy word for, say, dried peas and beans, almonds in particular. So almonds do have calcium, but it's not absorbed. So, that's something to keep in mind. And then seeds. And then one other tip about calcium supplements is that there are two forms that you can find in the drugstore. The one that you primarily see is calcium carbonate. It's very inexpensive. You're going to spend a lot less money for the calcium carbonate. And then there's another one called calcium citrate. The calcium carbonate, you want to take it with food. And then the calcium citrate is better absorbed, and you can take it with or without food. But both, and I think that's it. Okay. Looking at my notes. Vitamin D, if you are deficient in vitamin D, and a lot of us are, you are going to absorb less than 10% of the calcium that you have in your diet. In addition, vitamin D affects your muscle performance, balance, and boosts your risk of falling. So definitely want to have enough vitamin D in your bloodstream. So, you can go outside and it's synthesized in the skin in the summer sunlight. But the thing is, we're not doing that anymore. When we go out in the sun, we are slathered in sunscreen, and a lot of us are not going outside anyway. We're just not going out. And in the winter, fall, winter, and spring, it's not, in most parts, at least in the US, most of the areas, the sun's at the wrong angle, so we're not able to catch those UV rays. So Mother Nature actually intended for us to get the UV rays, and which turns a form of cholesterol that's just underneath our skin, that converts to vitamin D in the body. But because we're not doing that, we need to get it from food. Mother Nature did not put it in very many foods. So it's found naturally in a few things like egg yolk, oily fish, like the salmon that you see pictured there, liver. Some people like liver, a lot of us don't. And then specially treated mushrooms. So if you're looking for mushrooms with vitamin D, it'll say treated with UV light, higher in vitamin D. They're kind of hard to find. And then there is some vitamin D in certain fortified foods. It's added to milk, but in very small amounts. It's added to certain orange juice brands. Again, you have to look at the labels, and it's added to cereal. But it is, well, let's see, we're gonna go to the next slide here. So how much vitamin D do you need? So most nutrients, most say vitamins or even minerals, it'll talk about milligrams, 100 milligrams of something. Vitamin D in most cases is measured in what we call international units, or IUs. So for your age group, you can see how much you need. There's been speculation that we need more than that, but this is what the latest is. But as you can see, fortified foods, you're going to have to eat a lot of them, because they only have between 40 and 100 international units per serving. And I've got this, there was a study in the Journal of Bone Mineral Research last year, and it talked about, okay, so what if you have 2,000 international units of vitamin D? Well, it could be good for certain things, but it's not going to boost your bone density. So this is a picture of one brand, but there's all sorts of brands. You can get the store brands. Most people are going to need a supplement. There's D2 and there's D3. You want to look for the D3. And when you take vitamin D, you need to take it with fat, because it's a fat-soluble nutrient, fat-soluble vitamin, and a little bit of fat could be a little bit of salad dressing, or even just a piece of cheese, or you're taking it with a lunch that's got some fat in it. You're set there. And if you're buying a brand, you want to make sure you're like, this brand is very deceiving. You see the small print in the slide there, it says 2,000 IUs. They also have a brand, they also have a variety that is 5,000, and you don't want to take the 5,000, it's too much. Okay, so let's talk now about other nutrients beyond calcium and vitamins, vitamin D. So vitamin K is a nutrient that you hear a lot about. It helps direct the calcium to the bones. The body, it's a fat-soluble nutrient, but the body does not store it very long. There are two types, but don't worry about the two different types. The K1 is what you find in most items of the diet that most of us eat. You see the types of dark leafy green vegetables listed there, as well as soybean and canola oil. And I want to highlight the fact that the lettuce, it could be really any type of lettuce, even iceberg lettuce has some vitamin K. So if you're an iceberg person, I know for a while we dietitians were saying, stay away from iceberg. It doesn't have any nutrients in it. It's pale green. Don't worry about that. If you like a little iceberg for crunch, maybe mix some iceberg with some romaine or some leaf lettuce, and you're good to go. The body does convert some of the vitamin K1 to vitamin K2. Don't worry about the different types, but just make sure that you are eating these green leafy vegetables and other foods on a daily basis. There is no evidence to support vitamin K supplements. Few multivitamins contain the daily value of vitamin K. And how much do we need on a daily basis? We need between 150 and 200 micrograms. So that's mcg. So that's another way of measuring things. Vitamin C is also important in terms of bone health, or so we think. So research suggests a possible association between vitamin C and osteoporosis prevention. So we have some studies in animals, cell cultures, as well as epidemiologic studies, but clinical studies are lacking at this point. So, stay tuned, but vitamin C is an antioxidant vitamin, and it's good for a lot of things in our body. So definitely make sure that you eat multiples of these foods on every day. I had fun pulling these pictures. I thought it'd be kind of fun to see, okay, so maybe you can look at these slides or these pictures and say to yourself, okay, now how much of these do I eat? Okay, broccoli, tomatoes, that's a mango on the left, kiwi fruit, papaya, green pepper, red pepper, grapefruit, cantaloupe, strawberries are a really good source. And some of you may be surprised that potatoes are a good source of vitamin C. Yes, now I'm not talking about au gratins or the French fries at the drive-through, but I'm talking about, say, a whole potato that maybe you bake in the oven, or maybe you boil it with its jacket on. So if you have I'm going to give you a measurement. So if you have a potato that is 3 inches by just over 4 inches, you're going to get 34 milligrams of vitamin C. So that's pretty good. So if you pair that with something else, you've got your vitamin C for the day. So the RDA that's listed there is 90 milligrams. That's for men. For women who typically have smaller bodies, our needs are only 75 milligrams on a daily basis. Vitamin B12 can also play a role. It is found in animal proteins and in fortified cereals. If you are a vegan, you need to supplement, and nutritional yeast is a good way to do that. There's the RDA for that. I think I'm going to just go on. And then just plant compounds. You may have heard of phytonutrients or plant nutrients. We still don't know all of them, but there are hundreds, no, thousands, like tens of thousands probably. We haven't found them all yet. They are there, and they're there to help us with our health, whether it's heart health or our bone health or keeping diabetes at bay, and even keeping our mind sharp, reduction and delay of Alzheimer's disease. There are, again, thousands of plant compounds that are there. So one of my key takeaways of this presentation is to make sure that you eat a wide variety of plants on a daily basis. Does it have to be fresh? No, it could be frozen. It could even be canned. I have canned tomatoes. I have canned olives. What else do I have? I have a bunch of other ones. I have a lot of things in my freezer. I have frozen berries, frozen vegetables. So don't worry about the source. Just make sure that you eat them. Carotenoids is an example of a plant compound. Lycopene is one of them. It's the bright red color you find in these foods here. Everything's pretty much self-explanatory. Tomato sauce on the left, those are carrots on the right. Those reduce oxidative stress associated with the risk of osteoporosis. Magnesium is also a major constituent of bone. It helps convert vitamin D to its active form. You can find magnesium in the foods that are listed there. You don't want to take a magnesium supplement. It's just too easy to overtake the supplements, and supplements can interact with certain drugs, including the phosphates, I can't pronounce it, that some of you are taking. Potassium is an important mineral when it comes to bone health as well. Helps with calcium absorption, retention. You want to aim for about 4,700 milligrams. This is a list of foods that are high in potassium. And of course, potassium is important for blood pressure regulation, but don't really worry about, aiming for these foods that are high in potassium. Really, all fruits and vegetables will fill the bill. Phosphorus is an important part of the structure of bone. You can find phosphorus in a lot of, the wide variety of foods, a lot of animal protein foods, and also some plant. Trace minerals, we need them in just tiny little trace amounts. Here's a list that are good. Leafy greens, whole grains, nuts, seeds, beans. Selenium in particular is important, but all of these as well. Protein. We used to think that a high protein diet was detrimental to bone, that it was leading to osteoporosis, but now we're finding that we need a little bit more protein than we thought. So the emphasis these days is on less animal protein and more vegetable, fish, and dairy protein. So legumes, nuts, and seeds. So a rule of thumb is to take your weight divided by 2, and that'll give you the number of grams of protein you need in a day. And to put things in perspective, about 3 ounces of cooked meat, poultry, or fish will give you between 20 and 25 grams. Omega-3 fatty acids also may play a role in bone health. Okay, I'm just we're kind of running low on time. So some possible bone robbers. The studies are contradictory when it comes to sodium. Most of us Americans take in too much sodium anyway. The vast majority is from packaged and prepared foods, as well as restaurant meals. As a matter of fact, 70% of the sodium that we ingest, 70% of the sodium we eat are from processed foods, packaged prepared foods, and not from the salt shaker. If you are trying to cut back on your sodium, one tip is not to cook with it, but just to put the salt shaker at the table and just sprinkle a little bit on, because it's on your tongue and you can taste it. It's very interesting. So there are some surprising high sources of sodium. Breakfast cereals prepared, like cold breakfast cereals, soups, of course, processed meat, and bread and rolls. And foods that are not as high in sodium as we think are things like potato chips, because they put the salt on the outside so that our tongue tastes it. So it's kind of interesting. So sodium, of course, plays an important role in blood pressure. So most of us need to cut back on that anyway. Dr. Lewis talked about alcohol, too much alcohol influencing our bone health. Alcohol can affect our calcium status by reducing its absorption and by inhibiting enzymes in the liver that help convert vitamin D to its active form. So it should be consumed if you drink. Don't start to drink unless you're already drinking. But if you drink, you want to cut back to 1 to 2 servings a day for men and 1 serving for women. You definitely have an increased risk of fractures if you're drinking more than 4 servings a day or 2 a day. But the thing is, how much counts as a drink? And if you're drinking a glass of wine, it's 5 ounces. I want to show you a couple glasses that I have here. On your left, let's see, I'm doing this right. On your right is a wine glass that I got for my wedding in 1978. It's a small wine glass. So 5 ounces of wine is a serving, but if I put 5 ounces of wine in this bigger, newer wine glass, it would look like I didn't have enough. So look at your beverage glasses, whether it's for your highballs or your wine, and definitely make sure that you don't over imbibe. Carbonated soft drinks, we don't really know for sure. There looks like there's some risk with women, but we don't know if it's because of something inherent in the soft drinks or if it's because it's displacing dairy milk. Caffeine, we used to think that it is negative for our bone health, but it looks like it's okay. Moderate amounts don't appear to increase osteoporosis or the risk of fractures. And then tea, which has less caffeine, regular tea drinkers have higher bone mineral density. So that's something to keep in mind. Okay, so now we're going to talk about food, and I'm keeping an eye on the clock. So don't worry about the various nutrient amounts that I was telling you about. Don't worry so much about all these different foods that I was telling you about. Look at your overall dietary pattern and aim for at least 4 to 5 servings of vegetables and at least 3 to 4 servings of fruit each day. Okay, and a couple of, or actually 3 diets that you can look at for that have stood the test of time in terms of not only bone health, but reduction in Alzheimer's disease risk, helps with high blood pressure, helps with heart disease, helps with diabetes, are the Mediterranean diet, the flexitarian diet, and the DASH diet. The DASH diet stands for the dietary approaches to stop hypertension. So I'm half Italian and a quarter Greek. So I'm going to go towards the Mediterranean diet. That's the one I want to talk about. So here is a copy of the Mediterranean Diet Pyramid that has been issued actually a number of years ago by the Old Ways group. And you can just do an online search and you can download this picture. And it's not the specific foods, it's the fact that these foods work together. There's synergy, okay? The nutrients within the foods work together and help to keep us healthy. And interestingly, so the Mediterranean diet is based on vegetables, legumes, fruit, cereals, fish, olive oil, and dairy. The Mediterranean diet also is important with prostate cancer, okay? Not just bone health, but with prostate cancer, there was a study that came out in the journal Cancer last month. So the January 2021 issue found that it prevented disease progression among men with localized prostate cancer on active surveillance. And then another key component of, as you know, of the Mediterranean diet is olive oil, and in particular, extra virgin olive oil. I consider it like a magic elixir, but extra virgin olive oil has more than 30 phenolic compounds with antioxidant activities. And they have been found, these polyphenols stimulate the proliferation of osteoblasts. Those are the cells that build up bone. So swap out your other oils, cooking oils, for extra virgin olive oil. So a few menu ideas. So here's breakfast. So we've got avocado with an egg on top of it on some whole wheat toast, or maybe you can put some tomato on there or some spinach. On the right, we've got oatmeal with milk and fresh or frozen berries. Lower right-hand corner, we've got Greek yogurt with berries and nuts, or maybe you could make an omelet with tomato, onions, and peppers. So breakfast is a great way to not only take in whole grains, but it's a good way to get in some fruits and vegetables. And instead of a sandwich for lunch, how about building a one-dish lunch? Pick a smart carb, maybe some whole grains like brown rice or barley or wheat berries. And you're not going to cook it just for lunch, but you're going to have it in your refrigerator, that you you've cooked a batch of it, or maybe you've got it in your freezer in a small container. You're going to cook. You're going to take that as your base. You're going to pile on some veggies. And again, these vegetables might be some vegetables that you've made a day or two ago for dinner, and they're in your fridge, and you're going to add some protein. Again, it could be some leftover protein, some leftover meat, maybe a rotisserie chicken, top it with a fat, drizzle on some dressing, and you've got, so this is a good way to eat a nutrient-rich lunch, but it's also, you're cleaning out the refrigerator and you have little bits and pieces and you're not wasting, because food waste is something we're trying to get away from. And how about some dinner ideas? On the left, we've got some fish, beautiful fish. Top, we've got a sheet pan dinner. If you do an online search for sheet pan dinners, you're going to get 176 million hits. But here you just take as a matter of fact, yesterday's New York Times had an article about sheet pan dinners and Martha Stewart. So it was kind of fun to read. But it's basically, you take a protein source, a vegetable, and a starch, you put it in the oven, and you take it out. Done. And you're going to mix it with a little bit of olive oil. I do it with salmon a lot, and some little potatoes and maybe some green beans. Delicious. On the bottom, I've got that's a vegan, what is it? It's a red lentil soup with some pomegranate arils on top and some Greek yogurt. And in the upper right-hand corner is a pizza that I made with my very own hands, starting from scratch with flour and everything, yeast. But look at what are the ingredients on my homemade pizza. We've got tomato sauce, which is what? The lycopene. We've got the cheese, which has the calcium, and we've got the veggies. I've got some, as you can see, green pepper rings, and I've got onions, which you can't really tell, but there they are. Tomorrow night I'm making pizza too, and I'm going to throw some olives on instead. So just to sum up, so bone health is more than just simply calcium and vitamin D. The key takeaway is, eat a variety of foods to get enough of all the nutrients, not only calcium and vitamin D, but also vitamin C, vitamin K, potassium, phosphorus, magnesium, protein. It's needed for strong, healthy bones. It's your dietary pattern that's important. And, do you have to eat perfectly every day? Of course not. I don't. But if you can aim for like 90% really good diet, you can make a difference in not only your bone health, but your energy level, how well you sleep, and all the other things that we talked about. So thank you. And I'm going to let Dr. Lewis take it away.
Christine, thank you so much. That was really, really fascinating stuff. And Dr. Lewis, I think we're going to go back to your second set of slides where we'll learn a little bit more about bone health, specifically as it relates to prostate cancer.
Okay. I got stuck in the chat room. Great questions. Wish I was a faster typer and had more time. But maybe in the Q&A we can address some of those. So in the second half, we're talking about bone health, specifically in men with prostate cancer. So let's take our foot off the gas pedal. I know that first half is kind of quick, and slow down the pace. And for the next 20 minutes or so, talk about bone health in men with prostate cancer as it relates to androgen deprivation therapy and bone mets. Let's start by looking at the updated projections and estimates by the American Cancer Society for 2021 and compare them with the 2020 projections. And as you can see, the number of new cases and death factors, including earlier and better detection of prostate cancer and the fact that men are living longer. Prostate cancer continues to remain the most common cancer in men and the second leading cause of death. Couple definitions. Hormones are substances made by glands in the body that function as chemical signals that affect the actions of cells and tissues at various locations in the body, often reaching their targets by traveling through the bloodstream. Androgens, also known as male hormones. Testosterone, of course, is the most well-known androgen, primarily secreted from the testicles, but the adrenal glands, which lie on top of the kidneys, also produce a small amount. And one of the things that we did not learn for many, many years and decades was that prostate cancer cells can acquire the ability to make their own testosterone, which is not measurable with a blood test. And of course, androgens stimulate prostate cancer cells to grow. Androgen deprivation therapy, abbreviated ADT, also known as hormone therapy, certainly one of the primary and essential forms of treatment for prostate cancer over the last 60, 70 years, used for recurrent or more advanced prostate cancer. And of course, the basic premise behind ADT is to block the production and or the effects of testosterone and androgens on the body, and thus to slow or stop the growth of prostate cancer cells. ADT is not curative in any sense, but it certainly can slow down the growth and progression of prostate cancer. This can be accomplished by removing the testicles, or more commonly now by the administrations of medicines called LH-RH agonists or antagonists, which are administered via injections or implants under the skin. And many of you may be familiar with or on such drugs as Lupron, Eligard, Firmagon, Zoladex, and the like. Some patients remain on androgen deprivation on just an intermittent basis, and many others are on it for many, many years. In 1941, just a piece of history, Dr. Charles Huggins, a Canadian-born American physician, physiologist, and cancer researcher at the University of Chicago, who specialized in prostate cancer, was the first to discover and show that prostate cancer could be controlled by reducing testosterone, either with orchiectomy or giving female estrogens. And he was eventually, in 1966, 25 years later, awarded the Nobel Prize for Physiology or Medicine with that discovery. As Dr. Carl Sagan once stated, you have to know the past to understand the present. This is especially true as we look at the timeline history of, as it relates to the treatment of prostate cancer. I realize this is a busy slide, but I'd like to point out a few things. 1941, when Dr. Huggins made his discovery that reducing testosterone to castrate level, either by orchiectomy or female hormones, these two modalities were essentially the only methods available to treat advanced or metastatic prostate cancer up through 1985, a period of 44 years. And then in 1985, Lupron was approved. It was the first injectable medication that could reduce testosterone to a castrate level. Lupron did not improve survival rate any better than orchiectomy or DES, but it pretty much eliminated the need for the surgical removal of the testicles, which had an adverse and profound effect on many men, or the use of DES, because DES had been found to have an increased risk of adverse cardiac events. From 85 to 2004, there were other FDA-approved forms of injectables like Eligard, Trelstar, Firmagon, which were like Lupron, And there were several what's called non-steroidal androgen receptor antagonists, flutamide, bicalutamide, nilutamide. Some of you may know those names, but none of these new agents really improved the overall survival of advanced metastatic prostate cancer. And from 1941 to 2004, that's a period of 63 years, on average, after 12 to 24 months on androgen deprivation therapy, most men with prostate cancer would develop what's called castrate-resistant disease, where the prostate cancer would begin growing, spreading, and further metastasizing, even though testosterone levels at castrate levels. And many of these men died very slow, agonizing deaths, and treatment was just palliative when they developed the castrate-resistant stage. And then in 2004, things began to change. After years and years of various unsuccessful chemotherapy and other drug trials, Taxotere or docetaxel, a chemotherapy agent, was the first therapeutic drug to show a survival advantage in metastatic castrate-resistant prostate cancer. And in the last 10 years, well, since 2004, the last 15 or so years, 10 new drugs have now been approved for the treatment of advanced prostate cancer. We have now 2 chemotherapy drugs. We have 3 androgen receptor inhibitors. We have an androgen synthesis inhibitor. We have a vaccine, and we've got some additional radio therapeutic and some of these new checkpoint, what's called checkpoint immune inhibitors. So the last 15, 16 years has been surely an exciting time in prostate cancer. We're now prolonging life, so the more and more men who have advanced prostate cancer are dying with it rather than because of it. This slide illustrates the various stages or categories of advanced prostate cancer. Advanced indicating the prostate cancer is spread beyond the prostate, either at the time of initial diagnosis, or more often it's recurrence after treatment that was initially felt to be localized to the prostate. Advanced prostate cancer is not curable, as I mentioned, but generally very controllable now for many years, especially with these new therapeutic drugs that have become available. For patients who present with localized prostate cancer, like many of you have, patient comes in, PSA is elevated, maybe there's a nodule in the prostate, they get biopsied, found they have prostate cancer. They may have a CAT scan, bone scan, no signs of metastases. And then many of those men are treated with radiation or removal of the prostate with the intent to cure. And the fact is, many of these men are cured. But about anywhere from 25 to 40% of patients who have localized prostate cancer and treated with radiation or surgery will recur. And usually they recur because the PSA starts to rise long before there's any symptoms and long before there's any evidence of detectable metastatic disease. And they don't really recur because the surgery or the radiation wasn't effective in eradicating the cancer in the prostate. They recur because there was already microscopic cancer cells outside the prostate at the time that they were treated, but these cells were too small for our imaging studies to pick up. And so we call this the biochemical recurrent or PSA failure at this stage. And then these patients, as time goes on, may go on to develop metastatic castrate-sensitive prostate cancer. They may go on to develop non-metastatic castrate-resistant prostate cancer. And eventually, as the cancer progresses, they go on to develop metastatic castrate-resistant prostate cancer. And when these new drugs are approved nowadays, they're generally approved for these various spaces. Now, one drug, like enzalutamide, may get approval for all 3 of these stages, and another drug may just get approval for non-metastatic castrate-resistant prostate cancer, like darolutamide. And again, just a slide here to show all the new drugs that are now available for these various stages that occur. And as I said, from 1941 to 2004, we had nothing for these stages. It was all palliative. The one thing that you don't see here is androgen deprivation therapy. But all of these stages, all of these stages here, 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 and here, basically all these patients and here will be started on androgen deprivation therapy, and they will remain on androgen deprivation therapy the entire time. And the reason for that is because there's always a cell population that remains sensitive to androgen deprivation therapy. And it's the other prostate cancer cells that have mutated that don't respond to the androgen deprivation therapy that progress, and that's where these new therapies have been helpful in treating. So we call this the hypothalamic pituitary adrenal gonadal prostate axis. That's a mouthful. But this is where the various drugs work to try to decrease the production of testosterone to a castrate level. In our brain, there's a gland called the hypothalamus that secretes a hormone called LHRH, which acts on the pituitary, and the pituitary secretes a hormone called LH, or luteinizing hormone, that stimulates the testicle to make testosterone. A small amount of adrenal androgens comes from the adrenal gland, and then testosterone acts on the prostate cancer cell, other areas of the body. The management of advanced prostate cancer and men on ADT and various other prostate cancer therapeutics is often a struggle to maintain a balance between preserving quality of life and extending survival. This slide just shows you some of the many side effects or adverse effects from androgen deprivation therapy. And what we commonly warned our patients about if we started them on Lupron or Eligard or remove the testicles was, yeah, you're going to lose your sexual desire, you're going to lose the quality of your erections, you're going to develop hot flashes. But we really were remiss in sort of missing out all these other things that occur that we probably should have and still don't address as well as we can. But what the patient feels, there's these types of symptoms. What you see visibly are these types of symptoms, and what you don't see are cardiovascular effects, metabolic changes, anemia, and of course, what we're focusing on right here is loss of bone density. Another point is a certain amount of testosterone in our systems is metabolized into estrogen, estradiol being the most common hormone. So yes, we men do have estrogens, and actually it's the estrogen component that is more important in maintaining bone density. Testosterone is important in our growing years, and it's aimed at bone formation. It's really the estrogen which helps maintain the bone densities that we have. If 42% of men, as I said in the first part of our talk, if 42% of men over age 50 have either osteoporosis or osteopenia, then a significant number of men already have bone loss before even starting ADT. And the risks of osteoporosis and skeletal fracture are directly related to the time duration ADT. The longer you're on ADT, the more it's going to cause deaths, bone loss and morbidity. Bottom line, bone loss in men receiving ADT is not a trivial issue. This slide is just sort of a graphic view of what I just said. We have all these drugs, the anti-androgens, the LRH agonists, the androgen synthesis inhibitors like abiraterone. All these work by decreasing androgen activity. And when the androgen level, the testosterone goes down, there's less estrogen. And then this lack of androgen, lack of estrogen, work on the bone to cause decreased osteoblast activities. These are the cells that form bone. And there's an increase in osteoclast activity. These are the cells that break down bone. These are where our bone forming agents work to block this area. And so we get increased bone resorption and increased fracture risk. This was a chart review of patients who received ADT for a mean duration of just 2.7 years. And 77% were classified as having osteopenia or osteoporosis of the hip or spine. 27% had osteoporosis and 50% had osteopenia. The bar graph on the left shows that in men with prostate cancer on ADT, how the bone mineral density of lumbar spine and the hip decreases by 2 to 5% after just being on it for 12 months. most of the bone loss that occurs with ADT occurs in that very first year or two. So if it's going to be treated with bone therapy drugs like the bisphosphonates, denosumab, etc., these drugs often should be started at the onset of ADT if patients have osteopenia or osteoporosis going in. And then the graph on the right shows how the incidence of fractures increases in a linear fashion the longer one is on androgen deprivation therapy, so that the fracture rate's about 15 to 20% after 5 years. But look after more than 5 years on ADT. Marked increased incidence of fractures, almost 50% if you're on it for 8 or 9 years. And nowadays, some patients are on it for 8 to 9 years because of these newer drugs that prolong survival. One last graphic slide. This was men with prostate cancer who have a fracture and shows how they have reduced survival. So men with a history of a skeletal fracture have an overall survival of 10 years since the diagnosis of cancer, and men who have no history of skeletal fracture have a 3-year longer survival. So for men who are starting on androgen deprivation therapy, you want to get your vitamin D level checked. And if it's lower than 25 or 30, you should be on higher doses than the normal 800 to 1,000 milligrams a day. And of course, you want to make sure that your calcium intake is high too. And Christine very nicely showed the importance of calcium and vitamin D. And then you should have, because you're going to be on androgen deprivation therapy, you want to get a bone density DEXA test. And where appropriate, you'll also get FRAX assessment. And there's another type of X-ray that can be done at the time of X-ray, at the time of the Dexa scan, and that's called vertebral fracture assessment. On the basis of these results, if you've had a previous fragility fracture, we talked about that. If you have a T-score that's less than minus 2.5, or if you have a T-score in the range of -1 to -2.5, and other risk factors or FRAX assessment that shows you're at risk, then a discussion should take place about putting you on a bone agent, either one of the oral bisphosphonates like Fosamax or IV zoledronic acid, Zometa, or one of the rank ligand inhibitors such as denosumab. And that would be a discussion to have with your healthcare provider. And here are some of the drugs that we use to strengthen the bones in men who are being treated with androgen deprivation therapy. These are FDA approved. Fosamax and Actonel can be given daily or more commonly weekly dosing. There's the IV bisphosphonate, Zometa, which is given, monthly dosing. And then subcutaneous denosumab, which is becoming first line and shown to reduce the incidence of skeletal-related fractures and increase bone mass a little bit better than Zometa. And for patients who do not have bone mets, 60 milligrams every 6 months for the prevention of bone loss. And for patients who have metastatic disease, it's the same drug, just goes by a different name, Xgeva, and it's given at twice the dose and given every 4 weeks. Let's talk about bone mets. So this is, again, the natural history of prostate cancer. I alluded to this a little bit in earlier slides. Got initial diagnosis and therapy. Many of the patients with localized prostate cancer will be cured with radiation or surgery. For those who relapse, at some point, androgen deprivation therapy is started, and then you start getting bone loss. And as the cancer progresses, in those who it does progress, at some point they become castrate resistant. A number of different therapies now available are given to these patients, but at some point the cancer will progress, bone metastases form, and now you're at risk for what's called skeletal related events, which are a marker of morbidity and mortality. We'll discuss that. So when prostate cancer spreads, as many of you know, it tends to spread to the lymph nodes and the bones, and much less common to the viscera like lungs and liver and brain. The bones just are a fertile ground for the prostate cancer cell. It's like putting seed in fertile soil. So wherever there's a good amount of marrow, prostate cancer cells tend to be attracted to that area. Other cancers like GI cancers, not so much, but the prostate cancer and bone just seem to be a match made. The median survival of patients who have metastatic, castrate-resistant prostate cancer, so these are patients who have metastases to most likely the bones, is in the range of 13 to 33 months. And men with 10 or more bone mets have almost a 4-fold increased risk of death compared to men with 1 bone mets, and more than twice the risk of death than men with 2 bone mets. So bone mets is a marker of possible skeletal-related events to come, which is a marker of increased mortality. Multiple symptoms that one might not attribute to bone mets often occur. Of course, pain and discomfort might be expected, but certain like fatigue, generalized weakness, mild numbness, sensory loss, loss of appetite, anemia, all of these can be related to bone metastases. Most common way of diagnosing bone mets, nuclear bone scan, or nowadays PETs, sometimes CTs and MRIs as well. These are some of the drugs that may be used nowadays in the hormone sensitive and in the castrate resistant stages. But patients who are in these stages are on ADT all this time as these newer drugs may be added. Bone complications are also noted as skeletal related events. And there's 4 types of bone complications that occur as a result of bone mets. There's broken bones, also called a pathological fracture, the need for surgery to the bones, the need for radiation treatment to the bones, or pressure on the spinal cord called spinal cord compression. These are called skeletal-related events, and they're related to metastases to the bones. Within 1 month of diagnosis of bone mets, 1 in 4 patients suffered a bone complication, and within 3 months of bone mets, 1 in 3 suffered a bone complication. I'm just going to run through this a little bit quick here. So symptoms, patients may or may not present with pain, but those who don't present with pain have the same incidence of developing a bone complication within 2 years as those with pain. But once a bone complication does occur, the vast majority of patients do experience pain. These are the various treatments available to strengthen the bones: denosumab, zoledronic acid, radium-223, localized radiation to a painful area. Sometimes surgery for fractures are needed, and pain meds. Denosumab, which is Prolia, or Extiva, zoledronic acid, Zometa. Nofiga is given for patients who have bone mets, who are having bone symptoms and bone pain. And it's not only been shown to reduce bone pain, but it's also shown to increase survival. So it's one of those 9 or 10 drugs that improves survival, but in addition, treats the bone metastases by the radium being picked up by the cancer cells in the bone and slowing down their growth. And for those patients who have bone mets, maybe have just severe pain in one area, a brief course of radiation can be given to that bone with a high degree of success. And then surgery may be needed for patients who have bone fractures, spinal cord compression, and for patients who have pain in sort of a sequential Tylenol to the non-steroidals, to the opioids, to the steroids. All right, just a few summary slides. We'll end this part of the talk up. Male osteoporosis is common, costly, underappreciated, underdiagnosed, undertreated. Men are living longer, increasing risk for bone loss, osteopenia, osteoporosis, and related fragility fractures. The incidence of prostate cancer is increasing. Men with prostate cancer who are on ADT are living longer as a result of newer therapies, and the long-term consequences, particularly bone health, are of increasing importance. Androgen deprivation by surgical or medical castration contributes to loss of bone mineral density in men with prostate cancer. And ADT is used in men with prostate cancer in several different clinical settings. The risk for development of osteoporosis and related skeletal fractures and events increases with time and duration on ADT. Current national and international guidelines lack detailed recommendations developed specifically for managing cancer treatment and ADT-induced bone loss in men with prostate cancer, but this is improving. There's a lack of guidance as to the intervention thresholds that should be used to guide and initiate treatment, or the most appropriate pharmacological therapy in these men. This is again now starting to improve as it's getting more awareness. Evidence suggests that both men in general and men with prostate cancer receiving ADT often lack basic osteoporosis knowledge and do not actively seek to take measures to optimize bone health. Hopefully webinars like this is one way to get the message out. It's also unclear who should overall be responsible for managing one's bone health, many of whom will be managed in a multidisciplinary setting by many physicians. Who takes responsibility for this? The urologist, the oncologist, the primary care doc? Published surveys of urologists and oncologists found that clinicians lack confidence, time, and or resources in providing self-management advice to patients to optimize their bone health. Provision of individualized, patient-centered information can improve knowledge and engagement with appropriate lifestyle modifications. Dexa Scan T-scores, the Frax 10-year fracture risk, and clinical risk factors should all be considered when establishing patients' treatment plan. The NCCN, National Comprehensive Care Network, recommends following the National Osteoporosis Foundation guidelines and treatment recommendations. It's a mouthful. And although guidelines are very helpful, osteoporosis treatment should remain individualized through shared decision-making between the patient and clinician. And if you are a candidate for medication, choice of therapy is going to be based on efficacy, safety, cost, convenience, and other patient-related factors. And finally, be your own advocate. Be bone aware. Know your personal risk factors. Educate yourself about both prostate cancer and bone health, the available literature and reputable internet sites. And feel free to, and you may have to be the one to start the conversation with your healthcare providers, whether it's your primary care doc, your urologist, oncologist, rheumatologist, orthopod. We're all involved in this when it comes to bone health issues. All right, thank you very much. Back to you, Jamie.
Well, Dr. Lewis and Christine, thank you so much for those really, really great talks. I know I learned a lot. I have a couple questions for you. I know we're running a little over time, so we'll try to get through some questions quickly, but we did get a ton of questions before the presentation, so I want to hit on some of them. This one is actually for both Dr. Lewis and for Christine, because it came up in both the chat today and ahead of time. But is there concern for calcium supplementation or dairy intake in prostate cancer patients? Does that increase their risk of disease recurrence? Does that make their prostate cancer worse? Does it make their prostate cancer more likely to come back?
Dr. Lewis, would you like to start with this, please?
Yeah, so you asking, says the question, will calcium supplementation increase the risk of disease, Jamie? Did I get that right?
Yeah, that's a question that popped up in both ahead of time and in the Q&A tonight is, does eating dairy or supplementing with calcium increase your prostate cancer risks?
I don't know of any data that shows that. Obviously, it's needed and healthy for the bones, but I'm unaware of any data that shows that calcium supplement is adversely a risk factor for the prostate cancer. There is some question that too much calcium obviously could be a factor for kidney stones. There's some concern that too much calcium may have an adverse effect on the heart. So, it's like a lot of things, too much of a good thing can be bad too, but I'm not aware. I don't know if you are aware of any data that shows that, Jamie.
I am not. And so I wanted to pose that to the panel as well. My best guess is that because prostate cancer tends to metastasize to the bones, that it's easy to assume that anything that can lead to increased bone growth may affect prostate cancer as well. But I think it's important that we remind everyone that they're two totally different processes as far as I'm aware.
Yeah, great.
I'm not aware of any negative either. Something to keep in mind that I mentioned earlier is that it's it's nearly impossible to overdo it from food intake. You can't overdo calcium, or most of us can't easily. So try to get the majority of your calcium from food.
Awesome.
Yeah,
So
I
this
think that's
question is,
important, Christine, because go ahead.
no, I think I don't want to cut you off.
I think
Sorry.
okay. Yeah. Well, I think it's an important point is, and Christine went over very nicely how much calcium is needed. The recommendation is somewhere between 1,000 and 1,500 milligrams. And the more you can get that from food, the better. But you shouldn't be going out and taking 3,000, 4,000 milligrams, because then you're going to start having some adverse effects. So, try to get it from your food. Be aware of how much you're taking, but don't overload it.
So this is a question for Christine. And this was one of the questions we got ahead of time, but should prostate cancer patients eliminate red meat, dairy, sugar, whey protein, any kind of categorical thing from their diet? I know I get this all the time from both my patients and their family members.
Well, I think you have my philosophy to, a lot of it is common sense. And I said toward the end of my talk, you can try to make your diet 90% healthy. Some people are, I don't think there's any need to eliminate any of those foods, with the exception of sugar. And the questions that came in had to do with those foods, and do they promote or feed cancer? And I am not aware of any peer-reviewed evidence, any scientific evidence that shows that any of those foods promote cancer. Now, if you overdo it on, say, processed red meat, if you eat hot dogs and sausages and salami and bacon 3 times a day, every day of your life, well, that's not a good thing. But an occasional hamburger or Italian sausage sandwich, or if you have some sort of goodie with sugar in it once in a while, there's no problem with that.
Awesome.
Like Jamie, I too have a lot of patients ask, Doc, what do you recommend in terms of diet and supplement? And my general response is that whatever is heart healthy is prostate healthy.
That's very true.
And there's probably as many supplements out there as there are opinions, or maybe there's more opinions than supplements. We're in a society where we want to take a pill for everything. But I usually tell my patients you can probably spend your money better than on lots of supplements. A well-balanced diet, exercise, maintaining a good body weight, those are much more important than any specific pill or supplement that you're going to take.
Awesome. I totally agree. Quick question for Dr. Lewis. And this is something that I think comes up commonly when we're giving shorter terms of ADT to patients, for example, with radiation, newly diagnosed either intermediate or high risk prostate cancer. What are the risks for bone health for shorter term ADT? So talk about, the 6-month patient or even the 18 to 24-month patient. And is that significantly different from a patient that we're going to be considering long-term or even lifelong ADT?
Yeah, and that's a great question. So the general recommendation, if you're just going to be on ADT for 6 months, and that's all, your risk is minimal. But if you're going to be on it for 2 to sometimes 3 years, as some of those patients may be, you should have a bone density scan right off the bat to see where you're at. And one of the other things that we often forget about is you may only get 3 months or 6 months of ADT, but sometimes that 6 months of ADT keeps your testosterone suppressed for 2 years. Sometimes when you come off the ADT, a lot of testicles don't start making testosterone right away. Perhaps some of the women who are on birth controls for long periods of time, they come off the birth control pills, but the ovaries take a while to kick in. So even though you may be on ADT for 6 months, I've seen patients who take 2 or 3 years for the testosterone to come back. So they remain at risk. So I think my feeling is that if you're going to be on ADT for any period of time, especially 6 months or longer, get a bone density scan right off the bat just to see where you're at.
Great. Well, I think we're running down in time. We probably have time for about 2 more questions. So first one for Christine. What do you think we should be teaching our sons, grandsons, nephews, other relatives of survivors about the importance of maintaining a healthy lifestyle earlier in life?
Oh, wow, that is a fantastic question. So thank you to whoever posed that. I'm a mother. I'm a mother of 3. One is a son. I have 5 grandchildren, three of whom are little boys. I've got a couple of 7-year-olds and a 5-year-old. I think it's all about living a healthy lifestyle, similar to what Dr. Lewis just said. Encouraging and role modeling. We need to serve as role models to our children and our grandchildren. Role model healthy eating. Like again, 90% healthy eating. Learning how to cook at home. Planting a garden if you can. Bringing herbs into the house. Growing them in the side. We talk about exercise. Instead of saying the word exercise, a lot of people go, oh, exercise. But how about physical activity, regular physical activity, going for a walk, jumping on a trampoline, sleep, stress reduction, all those things, drinking water. What were some of the other things that you mentioned, Dr. Lewis? But all those things are, this is what we can do as role models. And it's teaching them that a healthy lifestyle is just normal. It's just normal living, but having some fun too.
Great, thank you. And then last question for Dr. Lewis is, where do you see the greatest needs for education regarding bone health in our prostate cancer patients? And what suggestions do you have for addressing these needs?
Yeah. I started the talk with that report from the 2004 Surgeon General. It's now 17 years later, and we really haven't made a great progress in getting the message out. So I think it's got to be almost like a groundswell, a ground roots campaign. We need men to take an active role in educating themselves. We need to take an active role in educating us as physicians. The problem is nowadays, we're just so busy in the office. You don't have the time to give the patients the knowledge that they have. But I think we can start the discussion, encourage patients, give them some written information, and just keep pounding the word out there from all levels that bone health is important, not just in women, but in men of all ages, and especially men with prostate cancer. How best to do that? Again, I think it's just a campaign, but I think patients need to be a little bit more proactive in their care, and physicians need to be a little bit more heads up. This is where in a practice, especially a busy practice, it's nice if you have a physician assistant or nurse practitioner or some designated person that can take the time. And with all these new drugs in with prostate cancer, you almost need a designated, what we call a champion in your office to sort of make sure that patients are getting their labs, they're getting their bone density scan, they're getting their PSAs, they're on the right drug. It's a lot involved that's tough for just one physician to do in a busy office and surgery day. So yeah, we can do better. And hopefully we will, Jamie.
Well, thank you both so much for this awesome presentation. I think that these talks and these answers were really, really fantastic. So thank you to the audience for being here and listening to our presentations. I'm looking at the chatter. I'm gonna say thank you to Gregory and thank you to Christine. We did actually talk about how to talk to people yesterday in the run through, but want to make sure that we're not being, absolutely don't want to be disrespectful, no manners here or anything like that. I do want to say thank you to our sponsor Amgen for allowing us to be able to put this presentation together, and thank you to the US2 staff for all the hard work in getting this session set up.
Yeah, thank you, everyone. And just this is Terry Lukowski again. Thank you guys all so much for joining us. Thanks, everyone, for hanging in there with us. This webinar was recorded. You will all be getting a copy of the webinar with some really great follow-up materials to go along with it, including a beautiful cookbook with healthy recipes. If you registered, if you're here listening, you will definitely get that email from us with recording of this presentation. So we also have, like we said, this is the first of 5 webinars. Our next webinar will be coming up in March, our next one. We'll be sending out emails and just stay tuned for that. We actually have a whole series of webinars coming up this year for 21 all the way through July. So thanks, everyone. Stay safe. And thanks for joining us again. Have a safe night, everyone.
Thanks.
Take care, everybody. Thank you so much.